This lesson is to look at the range of different treatments for schizophrenia. As you can see from this slide, there are a range of treatments, from changing diet, psychological treatments to very intrusive treatments involving lobotomy or ECT. But the focus of today's session is going to be on drug treatments. So the objectives for this session are to explore the different range of drug treatments that are available for schizophrenia. So, what are you required to do? The specification requires generally that for each treatment you are able to describe exactly what happens in the therapy, how the treatment works. To evaluate it, it would be useful if you could look at any potential side effects, ethical issues, and the general effectiveness of the treatment. If you do this, you should get a reasonable to effective evaluation. So, if you remember back to first year, we're going to link this now to the biological approach. The biological approach is based on the idea of a physical cause. So a physical cause would require a physical treatment. And that's linked here. So in the same way that you would treat cancer with chemotherapy, drugs, we would treat schizophrenia in the same way as a physical illness through drug treatments. And in this way it is linked to the biological assumptions. So this focuses on using physical methods to either eradicate, which is the aim, or to lessen some of the symptoms of schizophrenia. Again, please note that the aim of drug therapy is to remove all symptoms of schizophrenia or to relieve as many as possible. Again, what we're going to find with the evaluation is that this doesn't always happen, and this is one of the main problems. So, we're going to focus on drug treatments. Some of this information is now quite complex, but if we just start by talking about the idea that drug treatments are probably the most common and widely used treatment for schizophrenia. It states here that they have radically revolutionised the way schizophrenia sufferers are treated and cared for. Drug therapy came about when insulin therapy was discovered to help people who suffered from psychotic illnesses. And from this, a chemical lobotomy was developed in the form of a drug called chlorpromazine. And we're going to be looking at this drug as one of the examples of a typical antidepressant. So antipsychotic drugs became very popular in the 1960s and 70s, and this was seen as being very effective because it meant that not as many people had to be institutionalised into mental hospitals. At this time, particularly in America, it was the time of the anti-psychiatry movement, when lots of psychiatrists, including R.D. Laing and Rosenhan, were battling against the use of antipsychotic drugs as they felt that these hindered and exacerbated the symptoms of schizophrenia. I'll talk about the side effects later and why these could be a huge problem. So one of the reasons that drugs were so popular was that it meant that people didn't have to be institutionalised and could live in the community. And although they might not be able to function totally normally in the community, they could certainly live in sheltered accommodation or where they just had some daily or weekly support. So it was much more effective and certainly much more cost effective to have drug treatments. And finally, it was hypothesised by Lamb in 1984 that 2 out of 3 patients would spend their lives in a psychiatric institution. Psychiatric drugs reduced this greatly, and because of this, a lot of psychiatric institutions closed and weren't required anymore. So in terms of the contribution that psychiatric drugs have made to schizophrenia, they have had huge influences. They have revolutionised the way that the illness is treated. We could view this as a strength. So we need to look at the aim. So what are drug treatments actually for? Well, the idea is to improve concentration. One of the problems with schizophrenia is that patients are unable to concentrate. They report being unable to focus. In addition to this, they are designed to reduce and relieve symptoms of schizophrenia, nervousness, depression. They are to hopefully stop the voices. They are supposed to stop the paranoid and confused thinking. This is the aim of the treatment. At the end of this session, you should be able to judge whether you think this is a valid aim, whether this is actually correct. So, the antipsychotics that we're going to focus on are chlorpromazine and haloperidol. You don't really need to know the names of them, although I would try to remember chlorpromazine if you can. This is probably the most widely recognised treatment for schizophrenia. So, on a basic level, these work by blocking dopamine receptors. And if you can remember from the biological approach, the dopamine hypothesis suggests that schizophrenia is caused by abnormally high levels of dopamine active. Therefore, an antipsychotic drug works to block these dopamine receptors and therefore reducing some of the symptoms associated with high levels of dopamine. So, one of the main reasons for using these drugs is because they are very effective, arguably, at reducing the positive symptoms of schizophrenia. And if you remember, the positive symptoms are associated with additional symptoms such as hearing voices. But they can also reduce negative symptoms because people don't hear the voices, so they're not as withdrawn and are more willing to socialise. So this could be seen as a strength, as it could explain how useful these drugs are. So, in the 1950s, typical antipsychotic drugs came out, such as chlorpromazine, and the NHS recommended these. And then in the 1990s, a type of drug called the atypical antipsychotics were developed. And these are the ones that are mainly used today. So most NHS hospitals or psychiatric wards would recommend using atypical antipsychotics in the first instance and then go on to use typical antipsychotics if these don't work. We're going to discuss why this would be the case and what are some of the problems with this. The NHS recommend that when somebody commits to using one of these drugs, they continue with it. And this is to prevent further acute episodes. If you remember, schizophrenia is an episodic illness that no one can predict when it's going to happen. So somebody's schizophrenia could lie dormant for a couple of weeks or months. And this is one of the problems with the tablets, that the patient must remain on the tablets through the whole of the course of treatment. And again, we'll talk about this when we talk about problems associated with the treatment. I'm going to start now by looking at typical antipsychotic drugs. And typical antipsychotic drugs are the older drugs that were established in the 1950s. So these are quite old now and are not used as a first-line treatment by the NHS at present, although there are still a lot of patients who are on these drugs. So these are often referred to as conventional antipsychotics. And these are the type of drugs that basically sedate the patient very much. They are dopamine antagonists, and they basically work by blocking the action of dopamine. These drugs work based on the idea that the dopamine hypothesis is the correct explanation for schizophrenia. So, These work by binding to dopamine receptors, otherwise known as D2 receptors, but do not stimulate them. If there is a lack of stimulation of these dopamine receptors, the positive effects of schizophrenia can be eliminated. So by blocking the action of dopamine, you can stop hallucinations and delusions. One of the main drugs that you need to know for this is chlorpromazine. This is probably, as I mentioned earlier, the oldest antipsychotic drug. So now if we move on to the atypical, remember that the atypical drugs were developed in the 1990s, and they actually developed as a response to side effects associated with typical antipsychotic drugs. These also act on the dopamine system, but they actually act in a slightly different way. They're still based on the idea of excess of dopamine, as they also block the dopamine receptors. The problem is that they do not involve any other neurotransmitters, and the typical antipsychotics do work and involve other neurotransmitters. So these, you could argue, are perhaps not as harsh on the system. The side effects are not as great. And what they do, instead of blocking all dopamine transmission, they allow some dopamine transmission to happen. So they will allow a normal dopamine transmission. And this is quite different to the others that completely block. So the idea is that the patient feels normal. They have a normal dopamine surge. Now again, this doesn't happen with everybody, but the idea is that they can experience normal levels of dopamine. The key one in this would be quetiapine. Quetiapine is probably the first line treatment on the NHS at present for schizophrenia in patients who've not previously been treated. So now we're going to have a look at the evaluation. There are obviously lots of strengths and weaknesses of these treatments, but we're going to start by having a look at typical antipsychotics. So as you can see here are some of the main side effects of typical antipsychotics. And these first ones, drowsiness, shaking, trembling, muscle twitches and spasms, are probably the more common symptoms. The next one, tardive dyskinesia, is probably the worst symptom. And this is probably the main reason why these drugs are not favoured by most psychiatrists. So tardive dyskinesia is a condition that you cannot recover from, and it's associated with using chlorpromazine or similar drugs for 4 to 5 years and beyond. And this is an illness where you cannot control your muscle twitches or spasms. I will show you a video, and I will send some links to you of some videos of this so that you can have a look to see what tardive dyskinesia is like. So for many patients, when they consider going on this drug, they have to weigh up, would they prefer to have the symptoms of schizophrenia, or would they prefer to have tardive dyskinesia? And again, as it's often consented for by a friend or relative, it could be the friend or relative who decides which they would prefer. And this again comes down to how well the psychiatrist prepares the patient and how well the patient understands what's wrong with the tablets. If we now turn over to look at atypical antipsychotics, the side effects are arguably not as great. There are fewer serious side effects, and these are definitely a preferred method. So as you can see here, a lot of the side effects are side effects that we would generally associate with a lot of tablets today. Patients are more likely to take this medication because it doesn't have the serious side effects of the other. The problem is that this can have some effects on the immune system. but generally there are nowhere near as many side effects as there are with typical antipsychotics. So that brings into question which ones should the patient take and why, which are more effective. Well, obviously, because of the lack of side effects, the atypical antipsychotics are seen as being more useful because of the lack of side effects. However, are they as effective? Well, certainly there is a lack of ethical issues with atypical because most patients don't have to consent to possibly having tardive dyskinesia, and the side effects aren't as bad, so there aren't as many issues with ethics. One of the main reasons that typical antipsychotics has been criticised is because of the ethical issues and the idea of whether a patient can truly consent to this sort of care and whether it is fair for them to be asked to consent when they're perhaps not in control or understanding of reality. The other issue is that these typical antipsychotics are not seen as being effective at all with the negative symptoms of schizophrenia, whereas the atypical antipsychotics are slightly more effective for the negative symptoms of schizophrenia. Again, there isn't really a tablet, a drug that works for the negative symptoms of schizophrenia. So the antipsychotic movement in the 1960s and 70s stated that drug treatments were generally an inhumane treatment. And that was because people who could not consent to the treatment were being given treatments either sectioned under the Mental Health Act and forced to have the treatments, or an advocate or relation were consenting for them. And therefore it's appropriate to do a cost-benefit analysis. Although, again, this should really be the psychiatrist with the family deciding whether this is the appropriate course of treatment. For some people, if they become a risk to themselves and others, it might be that this is the only course of action. However, we must not forget that this is a human being and we must consider that they should have a say in their own care. The Human Rights Act 1988 states this. No one should be subjected to inhuman or degrading treatment. If you look at the videos of tardive dyskinesia sufferers, it could be argued that this breaches the Human Rights Act. Over the years, several tardive dyskinesia sufferers have had a settlement awarded in court for being given treatment against their will. If you look at the first slide on this presentation, which I haven't gone through, it gives you details of this settlement award. So, overall, we need to go back to look at the idea of how effective are these drug treatments. This ends this session. Thank you.